you so much. Thanks again, Sarah, and your team, amazing team at the PMD Alliance for continuing to host this. It's been kind of an interesting ride over the last year of these sorts of ways to socially connect here with our physically distant sort of restrictions, but hopefully things are getting better around the world and we'll be able to see each other and hug each other soon. We were just talking to Dr. Stoessl about hugging, which she is a big fan. So I'm excited to tell you a little bit about Jon Stoessl. Dr. Stoessl is an amazing Canadian neurologist who actually has an Order of Canada. He has a Wikipedia page that I found today, just really so talented. He's a member of the Order of Canada. I guess this is like an exclusive honor that he got in 2007, but there's a number of movement disorder neurologists that also have it. And I'd like to get one of those at some point. So this is like goals for the next 10 years or 20 years or whenever. But he is, he's located in British Columbia, and he's the director of the Pacific Parkinson's Research Center and the Parkinson Foundation Center of Excellence located at the University of British Columbia. He has had pretty wide training. He spent a lot of his training in the University of Western Ontario, which is in London, Ontario, spent a brief stint out in at McGill as well. And he's really just been a leader in the field of Parkinson's disease and inspired so many of us. Has done some groundbreaking research in imaging. And really when I think we've been talking about a lot of things around diagnosis and verifying people's diagnoses and things. And I know in the last year, you guys have wanted a talk on neuroimaging, and I couldn't think of anyone better to give this talk than Dr. Stoessl. So we finally twisted his arm and he found some time on his very busy schedule to join us today. Welcome, Jon. Thank you for joining us.
Thank you for having me. I'll just correct you briefly that I'm no longer the director of the Parkinson's Research Center at UBC. That role has been taken over by my colleague, Martin McEwen.
You have many amazing.
I have some other administrative roles, yeah.
and you're the editor of the Movement Disorders Journal too, which is
I am, yeah.
a lot of work, I know. So so you work day and night trying to help educate us out here and make sure that the research is on point and reject many of the papers that I send your way. I'm joking. But anyway, so maybe tell us a little bit about your journey. What led you to becoming a neurologist in the first place, and then what inspired you to take care of Parkinson's patients?
Well, I was always really interested in the brain, and in undergraduate university, before going into medical school, I did a combined program in physiology and psychology. And I remember there was a reading course, a seminar thing where we had to read stuff the night before and then go in and discuss it the next day. And there were a couple of papers that just gripped my attention, one of which was Wilder-Penfield describing recording from temporal lobe and stimulating temporal lobe during epilepsy surgery. And when he stimulated, people would get these intense flashbacks of things that had happened many years before in their lives. Of course, that has nothing to do with Parkinson's disease, but I remember sitting in the library late at night, spellbound and thinking, well, this is what I have to do with my life. So I went into neurology. And then as a junior neurology resident, I had to prepare a seminar, and I was hunting through the library looking for a topic. And I pulled out one of the earliest, if not the first, advances in neurology, which was on Huntington's disease. And it was a big fat book. And I started reading about neurotransmitters and the idea that release of chemicals in the brain could have such an impact on our behavior similarly fascinated me. And so from there, I was a short step to movement disorders, and my mentor, this was in the early 80s, had just recently moved from the National Institutes of Health to UBC. So I went out there to do a fellowship at the end of my residency.
And you've stayed ever since?
Well, I wanted to spend some more time doing basic science, so I went to England for a couple more years, and then I returned to Western on faculty there, and then an opportunity came up at UBC just about 25 years ago, actually. So I've been here since.
It's a beautiful part of the world. Well, thank you for joining us. So I know you've really sort of carved out this amazing niche with imaging, which is so interesting. And I love that story also about Wilder-Penfield. He inspired me as well. And a fellow Canadian, if I'm not mistaken, right? That work was done at the MNI, right? The Montreal Neuro.
He was an American originally, but
Okay.
moved to Montreal, yeah, which is where he did that work. Yeah.
Yeah, so cool, so cool. Well, I think the brain is cool. I think that's why many of us went into it, and it continues to just fascinate you every day. You see a patient, and you're like, wow, I wonder why that happened. So anyway, maybe you can help us understand a little bit. I know one of my favorite papers that you wrote was on the placebo effect, and I know you're going to teach us a little bit about the imaging of a host of things related to Parkinson's. So maybe I'll let you get started on the talk so we can kind of hear from you, and then we'll have a little bit of discussion and Q&A at the end.
Okay, great. I will just see if I can manage to share this. And is this working okay?
Mm-hmm. Perfect.
All right, I will just get going. Well, thanks very much for having me. This is a picture of the building where I work now, or where I was working pre-COVID, the Djavad Mowafaghian Centre for Brain Health, which is relevant here because it was really built as a translational center where there would be both clinical and basic science activities happening in the building to try and bring people together. So why do we need imaging? Well, the answer to that should be simple. This is a Rembrandt painting, the anatomy lesson, and it's because we can't do what they're doing here. The brain is in a very hard box. We don't have good blood tests to measure a lot of the things we're interested in. We can't really just go and scoop out a hunk of brain to look at it. And even if we could, much of the time it wouldn't be that informative because a lot of the changes that are relevant to neurological disease are functional changes. So imaging has advanced enormously in the past several years. And actually at this point, there are more than 1,000 papers per year on imaging in Parkinson's disease. So I'm obviously not going to talk about all of those. But what are the things we can do? Well, diagnosis is obviously an important application, although in my view, not the most important. We can see whether people have dopamine loss or not. In other words, like Parkinson's or more like essential tremor. Important for us is to differentiate between typical Parkinson's and so-called Parkinson plus, like multiple system atrophy or progressive supranuclear palsy. But a major interest in imaging is whether we can use it to measure disease progression. And this is going to become increasingly important as people try to develop drugs to slow the progression of Parkinson's and to see whether the treatments actually do what they're supposed to do. We may be also able to use imaging to personalize medicine, to stratify people for entry into clinical trials, to try and identify people before they actually develop disease, and possibly even to predict the trajectory of disease and complications of disease and its therapy. And finally, as Indu and I have already discussed, most of us got into this because we're really interested in the brain, and imaging is a great way to understand brain function. So to just quickly fly through a lot of these things, for diagnosis, probably these days, the most important tool is MRI. You can see structural changes. This is looking at PSP as opposed to Parkinson's, and there are some characteristic features, thinning of the midbrain here leading to the so-called hummingbird sign, and on looking at it from a different angle, the so-called Mickey Mouse sign, which I guess would be good for people who are based in LA. And you can actually do formal measurements on the brain. You can actually look at this area and compare the ratio between the two to get a more objective measure that allows you to make diagnosis. But MRI does a lot more things besides looking at gross structure. So this is work from France where the authors looked at gray matter density, iron deposition, diffusion of water in the brain, and the degree to which water molecules line up in the brain. And in this case, it's to differentiate multiple system atrophy from Parkinson's because there are characteristic changes here. Now, everybody's interested in dopamine imaging because, of course, dopamine is the molecule that's important in Parkinson's. And we do have several means to assess dopamine using imaging that I'll talk about, but I just want to emphasize that all of these forms of imaging may be useful to tell you whether or not you have dopamine deficiency. In other words, is it Parkinson's-like, or is it more like essential tremor, or a few other things? But they don't actually allow you to do the more challenging problem clinically, which is to differentiate between Parkinson's and atypical Parkinson's, not with dopamine imaging, but there are other methods to do that. This is using PET to look at glucose use in the brain. And you can see there is a characteristic pattern that is seen in Parkinson's disease with increased activity in some areas, decreased activity in others. And the important issue is that pattern is quite different in other conditions that produce Parkinsonism. So multiple system atrophy, you see reduction in the basal ganglia instead of an increase. You also see a reduction in the cerebellum here, another area important for motor control. And you see different patterns again for progressive supranuclear palsy or other conditions that result in Parkinsonism. Now we have several ways of imaging dopamine function in the brain. Probably the best known one these days is using a radio tracer that binds to the dopamine transporter. This is responsible for taking dopamine up back into the nerve cell once it's been released. And it's the target of many popular drugs because this is where cocaine works, by blocking dopamine reuptake. So in fact, a lot of the agents used to image dopamine transporter are cocaine analogs, the so-called tropanes. But regardless of which means you use, this is fluorodopa, which is like levodopa. This is dopamine transporter, and this is a different molecule. You see a very similar pattern in Parkinson's compared to healthy, where you get the back part of the striatum is affected first, and it's usually affected in an asymmetric fashion. The problem is, what does it mean? Well, for many years, we have thought with reasonable evidence that there's a relationship between dopamine imaging and the number of surviving dopamine nerve cells. So this was done with fluorodopa by colleagues at UBC. This is done with the dopamine transporter, very similar picture, but in fact, there is now some controversy over this. This is more recent work done in Finland, where they're again looking at dopamine transporter SPECT, and they've found no relationship between the imaging marker and the number of surviving dopamine neurons when they counted them at autopsy. Well, you could argue that if there's a big delay between having the scan and having the post-mortem examination, we usually hope there is some delay between those two, that might lead to a false negative outcome. So they then looked at people where it was a relatively short interval, and they still found no relationship. And same thing when they looked at tyrosine hydroxylase, so a marker of dopamine neurons in the striatum rather than in the substantia nigra. So while there are problems with this study, it means we have to be cautious in our interpretation of the scans. And that's shown in other work here. So we've also assumed that these scans give us a good marker of disease progression. That appears to be the case here. This is our data from the Parkinson's Progression Marker Initiative, funded by Michael J. Fox Foundation. And you can see there appears to be a relationship between disease severity and the dopamine imaging marker. But that's really only true. Oh, I've just lost my, sorry about that. I've just lost my PowerPoint.
You can just try to share it again.
Yeah, well, it's crashed actually. So I'm just waiting for it to open up.
Okay, well, in the meantime, you could just do some interpretive dance maybe or something.
That's not going to happen, but we might have peace in the Middle East first. So I'm back on here, but I'm not sure if I'm sharing or not.
Not yet.
Okay. How's that?
Yep. Yep.
Okay, sorry about that. That's a first. Um, so there appears to be a relationship here, but that's true only if you include both healthy people and people with Parkinson's. In fact, if you restrict it to the people with Parkinson's, you can see there's not a very good relationship at all between clinical severity and the imaging marker. And perhaps of greater concern, there's not a good relationship between the degree of change in the imaging marker and the degree of change clinically. And while both are imperfect measures, at the end of the day, we're still interested in knowing how people are doing clinically. So it's also being suggested that this imaging may be a good way to select people for involvement in a trial, because you obviously don't want to include people who don't really have Parkinson's. And that's absolutely fair. But you can see here, if you look at the people who have negative SPECT and positive SPECT, there is a difference. These people progress more rapidly than these people, but it's still not a perfect separation. So in the people who had a clinically important change over time, the DAT scan was abnormal in the majority of them, but a number of them actually had normal scans. And of the people who didn't have important clinical change over time, only 80% had a deficit in the DAT scan, which means then that the people who had a normal scan, about a third of those actually showed clinically important change, meaning that the separation between those who have Parkinson's and those who do not in this study was imperfect. It's still not bad, but it's not perfect. And then this is the part that I think is really challenging, is that you can see changes in imaging without improvement in clinical outcome when you do a variety of interventions. In other words, you can cure the PET scan, but too bad about the patient. And so here's one example. This is from fetal transplant for Parkinson's disease. You can see the PET scan has improved dramatically, but if you actually look at the clinical scores, there was no change over time. So somebody who still responded to levodopa, but no improvement following the transplant. And this is another example with GDNF, a growth factor that's used for Parkinson's. And here, if you compare to placebo to GDNF, you can see that in GDNF treatment, you can actually reverse the abnormality in PET. But this study failed to reach its primary outcome in terms of clinical improvement. Now, that's not a dead story, because there is still some signal suggesting that there may be interest in pursuing the therapy, but it's not as clear-cut as we would all like. So there are other measures besides nuclear medicine approaches that involve radioactivity. One is to measure iron in the brain. I'm not going to go over this in detail, and it's still, I would say, a work in progress. But there is some change in measures of iron that you can get using MRI over time, and there may be some relationship to clinical scores. It's limited, however. The other one that looks potentially quite interesting is neuromelanin, which is a pigment that's formed in dopamine nerve cells. And neuromelanin does change over time, and it appears to correlate with markers of dopamine, with dopamine transporter SPECT. MRI is also very good for imaging water. This is work done by my colleague David Valancourt at the University of Florida. And you can see there's a big difference if you look from baseline to a year at the change in free water. There's a big difference between people with Parkinson's and healthy controls. And this increase continues over at least the first few years of the illness, suggesting that it may be a good approach to monitor disease progression. But they've done something else that's really quite neat. This is an international collaboration with David at the helm and Indu's colleague, Michael Oken, at the same institution. And they've used the diffusion imaging but they've applied machine learning to try and automatically detect changes. And you can see that they can separate Parkinson's versus atypical Parkinson's with a very high degree of sensitivity and specificity. And not only that, by looking at the pattern of diffusion abnormalities, they can differentiate between different forms of atypical Parkinson's. So this looks pretty exciting, actually, for the future. And because it's automated, in theory, you can make this kind of software available to people around the world, because to actually do the study requires very highly specialized expertise. Imaging, if you're going to try and devise therapies for disease modification, then you need to know that the treatment is actually doing what it's supposed to. And a big issue with the brain is it's protected by a blood-brain barrier. So first of all, you should have some idea that the treatment you're using will cross from the bloodstream into the brain. That is a much bigger challenge in dealing with neurological disease than in most other conditions. And then you need to know that it's actually working where it's supposed to. So the details of this example are of no importance whatsoever. This is a drug that blocks adenosine receptors, and it just shows that you can use PET to demonstrate that as you give an increased dose of the drug, it does indeed progressively block more adenosine receptors. That's reassuring. However, in terms of disease modification, it's important to remember that just because you demonstrate so-called target engagement, that the drug gets where it's supposed to and does what you think it's supposed to, does not necessarily mean that you get the outcome that you want. This example is not from Parkinson's, it's rather from the Alzheimer's disease literature, and a very, very highly publicized example. So this is a monoclonal antibody that's designed to mop up beta amyloid that's abnormally deposited in Alzheimer's disease. And you can see just by looking at the pictures, there's a reduction in amyloid in the people who got the active treatment compared to baseline. And that is shown quantitatively here. If you just look at the ochre colored bars, which are the placebo group, they don't really change much over a year, but as you give higher doses of drug, you get a progressive reduction in amyloid deposition in the brain. And that seems to be associated with some clinical improvement. But as I'm sure many, if not all of you are already aware, whether or not this treatment actually has an important impact in Alzheimer's disease has been the subject of enormous controversy. And you'll see this, this web page is from last month, and this has been all over the New York Times. There's been a lot of controversy about the approval of this treatment by the FDA, and as far as I know, it's still on ice. And we have similar problems in attempting to assess Parkinson's, except perhaps even bigger challenges because we don't have as good a marker. I'll talk about that. So one of the challenges in attempting to treat people with neurodegenerative disease is the feeling that by the time you actually make the diagnosis, a lot of the damage has already been done. So you want to pick people up in the earliest possible stages if you're going to do something about it, and possibly even before they get disease. Well, obviously you can't go around offering treatment to everyone you meet on the street. So it has to be people who are at increased risk of having Parkinson's. And there are a few conditions that predict increased risk. One of them is REM sleep behavior disorder, where you act out your dreams. Normally, when we dream, we're paralyzed. But in people with Parkinson's, the switch that controls that isn't working. And so that's paradoxically a time when they may be very mobile. So there are several ways you can look at brain function in people with REM behavior disorder. This is looking again at melanin in the brain, and you can see it's deposited in the substantia nigra and in the noradrenaline producing cells of the locus ceruleus. Now you compare this to this. This is somebody who has Parkinson's and REM behavior disorder, and you can see there's a marked difference between the two. But here is somebody who's got RBD but does not have Parkinson's, even though they're obviously at increased risk. And you can again see this abnormality. So this may be an interesting measure to look at. Here is a place where dopamine imaging is definitely of interest. This is dopamine transporter SPECT, looking at healthy people and people with RBD. That was the original publication, and the same authors have followed up more recently with a paper comparing people with RBD who have normal imaging and those who have abnormal dopamine transporter imaging. And you can see there's a big separation. These are the people who go on to develop Parkinson's. This can also be done with glucose imaging. This is again work by my colleague David Eidelberg in New York. And again, I showed you this pattern before in a slightly different form. This is the so-called Parkinson's related pattern of glucose metabolism. And that is expressed in people with REM behavior disorder in two separate cohorts. And if you actually look at the expression of this abnormality, the people who have REM behavior disorder and have a normal score stay stable. The people who have RBD and go on to develop Parkinson's are the ones who score high on this measure. And then there are some people with RBD who actually score quite low. Well, RBD is not only a risk for Parkinson's, it's a risk factor for other synucleinopathies like MSA. These people actually ended up having MSA, although they didn't have it at the time of the original scan. One of the other risks for Parkinson's is an abnormal sense of smell. This is one that's attracted a lot of attention in the last year because of the effects of COVID. And this just shows people who have loss of smell and the people who have a dopamine transporter scan deficit versus those who do not. And you can see there's a big difference in the risk of developing Parkinson's. And then, of course, if you look at people who have genetic abnormalities that are known to be associated with Parkinson's, you can study those people before they actually go on to develop disease. Now, most Parkinson's is, of course, not due to simple Mendelian genetics, but there are a few examples where it is. This is one where we're looking at people with mutations in the LRRK2 gene. And you can see healthy control. This is dopamine transporter PET, somebody with Parkinson's, and then somebody in the middle who has the gene mutation but doesn't have any evidence of Parkinsonism. And you can see they've got a striking abnormality here, which progresses over time in a way that's very similar to Parkinson's. So this may be a good way to model what's happening in people before they get disease. So this allows us to do some things that we might not otherwise be able to do if we can look at this high risk group. We can use PET to look at the activity of other chemicals in the brain. One important one is serotonin. And when we started this study, we actually predicted that people would have abnormally low serotonin activity, as is seen in Parkinson's disease. But in the people who had LRRK2 mutations, they actually had an increase in some regions of the brain, which was totally unexpected. In contrast, if you look at a different mutation, this is work done by colleagues in the UK, they looked at people with mutations in a different gene, which is the gene encoding alpha-synuclein. And on the left here are dopamine transporter images. On the right is the serotonin imaging. And you can see that if you compare healthy to Parkinson's, there is some reduction. And now if you look at the asymptomatic mutation carriers, you see actually quite a striking reduction here, suggesting that the two genetic forms of Parkinson's actually behave quite differently, which may not be a huge surprise because they behave differently clinically as well. And we can do that looking at a different chemical system, which is acetylcholine. And acetylcholine is very important in Parkinson's because if you lose acetylcholine activity, that may be associated with cognitive decline, with loss of sense of smell, with abnormalities in postural control, and with REM sleep behavior disorder that I talked about before. So we did basically the same study as I showed you before with serotonin, this time looking at acetylcholine. And again, to our surprise, instead of finding the reduction that we were expecting to see in people who had mutations prior to them getting the disease, we found the exact opposite, that activity was actually increased. And I'm not going to spend a lot of time on this, but when you think about it, what we're probably seeing is the brain's efforts to compensate for the disease that has been present in somebody with a genetic mutation. That abnormality has been present for their entire life. They don't develop Parkinson's until much later, but they have their entire life to compensate for some of the other things that are going on. And we know that people with LRRK2 Parkinson's are less likely to have REM behavior disorder and less likely to have cognitive loss as a manifestation of their Parkinson's. So these findings fit very much with that. What we'd really like to do, of course, is to image the underlying pathology in Parkinson's, and this also may give insights into treatments. So one of the processes that is of great interest in neurodegeneration is the possibility that abnormal inflammation may contribute to disease and its progression. If that were true, then you could give anti-inflammatory agents. And there is indeed a suggestion that people who take anti-inflammatory agents may be partially protected against neurodegenerative diseases. So this is again an example of REM behavior disorder, only this time you can see this individual has normal dopamine in the basal ganglia, doesn't yet have Parkinson's, but they already are showing evidence of inflammation in the substantia nigra, suggesting that inflammation may actually be an important early manifestation of synucleinopathy. However, there are huge challenges associated with trying to image inflammation in the brain. There are genetic variants that have nothing to do with whether or not you have Parkinson's disease. So here it shows that the binding is affected by the variant, but not by the diagnosis. So that's a big problem. And the other thing is we don't actually know how to interpret the changes because inflammation may sometimes be a positive thing and may protect. And so here's an example again from Alzheimer's disease, where the people who have more evidence of inflammation in the brain are actually less likely to progress from minimal cognitive impairment to symptomatic Alzheimer's disease, or to progress more slowly once they develop Alzheimer's disease. And we don't know if this is the case in Parkinson's. Of course, the holy grail of imaging in Parkinson's would be to image the abnormal deposition of alpha-synuclein, which is the protein that is abnormally folded and associated with Parkinson's, although some people argue about the significance of that. We don't yet have a good agent for alpha-synuclein, but I will show you some preliminary material. This is an agent that binds to tau, which is another protein whose abnormal folding is associated with Alzheimer's disease and in a somewhat different form with progressive supranuclear palsy. So this is one particular tracer. There are several out there now. A fairly recent paper showing abnormal uptake in the brains of people with PSP and Alzheimer's disease, but not in people with Parkinson's disease. We actually did studies in collaboration with colleagues in Japan using a different tracer for tau. And we saw that, as expected, there was some increased uptake in the brains of people with PSP. But to our surprise, we saw increased uptake in people who had mutations in the alpha-synuclein gene, but did not yet have disease. This strongly suggests that the agent is binding to alpha-synuclein as well as to tau, and can therefore be useful to us to study Parkinson's disease. And this is work that has not yet been published. I hope it will be published someday. I guess I'd better not send it to movement disorders. This is Michele Matarazzo, who was a fellow working with us in Vancouver, but has now returned to Spain. And now he's using this tracer to look at people with Parkinson's, and you'll see there's increased uptake in the basal ganglia of people with Parkinson's, but it's more in the nerve terminal regions than in the cell body regions, which is actually quite interesting because it may give us some insights into where Parkinson's starts in the brain. People tend to always focus on the cell body regions, and actually the nerve terminals where they project may be more important. And then finally, I mentioned that we have collaborators in Japan, and they have recently reported a new tracer that's somewhat related, that they think is more selective for alpha-synuclein, and this is shown here in an animal model, but this is extremely recent work that is so far, to my knowledge, just on a preprint server. And I'm nearly done. A few more slides. So one of the last things I want to talk about is whether we can use imaging to actually predict disease trajectory. That would be of obvious interest for clinical reasons, but perhaps even more so for clinical trials of disease-modifying therapies, because not everybody behaves the same way. And so if you can have a more homogeneous group, then it would be easier to detect the effects of a disease-modifying treatment. So we don't usually think of Parkinson's as being associated with a lot of brain shrinkage, of atrophy. But in fact, if you do careful measurements, there is some. And the pattern of atrophy follows the degree of connectivity with the dopamine neurons in the substantia nigra. This is work done by Alain Daguerre at McGill. And they can calculate an atrophy score which actually correlates with the degree of deterioration when they look at a global clinical composite measure. I mentioned before the importance of acetylcholine for cognition, and I showed you some chemical types of scanning, but this is anatomical scanning looking at the basal forebrain nuclei, and work done in England. If you look at people who have a shrinkage versus those who do not, you can see there's a big separation. They all have normal cognition at baseline, but over time, the people who have an abnormal nucleus basalis actually go on to develop cognitive impairment. And this next one is an example that I find absolutely fascinating. In this case, the authors who are in Italy are looking at activation, different networks of activation in the brain. And they're looking at people with early Parkinson's before they're on drug treatment. And there are changes in activation that predict the future development of impulsive compulsive disorders once people start on dopamine agonist therapy, which, as many of you are aware, is a major detriment to the use of these medications. So it suggests you might actually be able to predict, and it just shows you that depending on which pattern of connectivity you're looking at, it correlates with the ICD scores and also with the time to developing ICD. So I did promise I would talk about brain function. These are PET scans from the same individual before treatment and after treatment. In this case, a reduction in binding, as you see here, actually reflects increased dopamine release in the brain. So what was this magic treatment? Well, it was actually a placebo injection. And what it tells us is that even in Parkinson's, the brain is capable of releasing dopamine in response to anticipation of a therapeutic response, which is really, when you think about it, just like anticipating a reward. So we then went on to look at what happens when you tell people how likely they are to get active drug, because it's not all the same. So in this study, we looked at people at baseline. We then gave them active levodopa when they knew they were getting active levodopa. And then we gave them a capsule and we told them they had a 0, 25, 75, or 100% chance of getting active drug for their third scan. Only no matter what we told them, it was a placebo each time. And what you can see is that the different probabilities of getting active drug were not all identical, and that people released dopamine when they were told there was a 75% probability of getting the active drug. And the degree of dopamine release in response to placebo was strongly correlated to the degree of dopamine release in response to active drug. This is Sarah Lidstone, who was the graduate student who did this work more than 10 years ago, who's now a movement disorders neurologist in Toronto, interested in integrated care, actually, in multidisciplinary care for movement disorders. And we have other ways to elicit dopamine release in the brain. Everybody knows about the benefits of exercise. And this shows that if you take people at baseline and you then subject them either to an intense aerobic exercise program or a control group, the people who engage in intense aerobic exercise release more dopamine in the brain when you stimulate over the surface of the skull with transcranial magnetic stimulation. Not only that, they also activate reward areas in the brain. This is determined in the MRI scanner when they're given a card task to play. So exercise clearly has beneficial impact here. And finally, I'd just like to remind you that the loss of dopamine in the Parkinson brain is not uniform. It tends to focus on certain areas of the basal ganglia. And if you look pathologically, there are certain areas of the substantia nigra that are more prone to lose cells. Function in the basal ganglia isn't homogeneous. There's mapping, both of motor function, so that the bottom of the striatum is thought to be responsible for controlling face. The top is thought to be responsible for controlling the leg. But there's not only segregation in terms of motor function, but also in terms of cognition versus motor versus reward. And so this is, I think, my last slide. And I want to show you a very new approach. This is my colleague Vesna Sosi, who's a physicist, and she's standing in front of what looks like a scanner. But this scanner is a little bit different because it isn't either a PET or an MRI scanner. It's actually both in one. And what this allows us to do is simultaneously look at the patterns of activation in the brain and chemical changes using PET. And so this shows a pattern of dopamine release when the subject in the scanner is performing a task. And what we're now doing is trying to compare different parts of the body, but also motor versus reward versus cognitive tasks. This is the graduate student who is working with Vesna, who has done, this is in very early stages. This was the first subject and just studied in January, end of January. And this is the graduate student who is actually doing the neuroscience graduate student. And she's standing beside the first subject whose brain activity is shown up here. And as you can see, we're obeying physical distancing and PPE requirements. But it's a really exciting approach to better understand brain function. So I'm going to stop here and stop sharing my screen, and we seem to have got through this without any further catastrophes. So I'll be happy to take questions or talk with
Yeah.
you, Indu.
That was amazing. I mean, it just shows the complexity, honestly, of this field. It's just like, so many different types of scans, so many different types of neurochemicals, so many aspects of, each sort of thing. And even, the fact that placebo influences things is another layer of complexity. So I think we realize why it's so hard to, I think, do these studies in the first place. There's been just sort of a hope to just clarify in a very basic way, what is like PET scan, what is a SPECT scan, and versus an MRI. I think people say here they know what an MRI is because they've got it on their bad knees and backs, but this other stuff is a little bit more esoteric, I think. So if you could just sort of break it down.
So good question. MRI is predominantly a structural type of imaging. It stands for magnetic resonance imaging, and it basically involves applying a magnetic pulse and then looking at a variety of, as the molecules relax, when you apply the pulse, they take on a different direction. And then as you look at the relaxation, as they return to baseline, you can measure a number of different things. But as you can already tell, I'm not an expert on MRI. So PET is a positron emission tomography, and SPECT is single photon emission computed tomography. They're both very highly related concepts. Both of them involve administering a drug that's being tagged with a tiny amount of radioactivity. And I want to emphasize the amount of radioactivity is completely harmless. That drug will then be taken up specifically by certain areas. And the difference is that SPECT requires single photon emission, so can be detected with a gamma counter, whereas PET requires a highly unstable tracer that emits a positron. And positrons are by nature unstable, so they look around for an electron nearby. And when the positron and the electron meet, they do that. And you get, instead of one gamma ray, you get two gamma rays given off at 180 degrees, so in opposite directions. And then you have a whole complex array of detectors that measure the coincidence reaction. All you're doing is measuring radioactivity. So what these require is some kind of a model that you can convert the measured radioactivity into a biological function of interest. So it's a very complex technique.
So it sounds like the MRI is basically structure. So you're just seeing kind of like a map, right? It just literally shows you a map of where the structures are and kind of, so in Parkinson's, generally, the structures are in the right place. And so a regular MRI, if people are getting them and there isn't measurements of these, little details like you had sort of talked about, you can measure atrophy and things like that of how much tissue is occupying what area on a map. The map is just basically the structure, but then these other two things are more about the function, right? So how the cells are functioning, what they're taking up in terms of chemicals, and you're able to tag these and measure them in this sort of more sort of specialized way. That it sounds like the DAT scan is more available. The SPECT scans are easier to do because it doesn't require this big process.
Easier, yeah, more generally available, although still expensive. And in general, what you say is true about MRI, but there have been enormous advances in MRI, and it's a really rapidly growing field. So you can actually measure function with MRI, where so-called functional MRI, where you look at patterns of activation, and I showed some examples of that, and that's what we're doing in the last slide that I showed. MRI can also, because it looks at water and the movement of water molecules, it may give you more detailed structural information than just what the brain looks like, although it gives wonderful pictures of what the brain looks like. And then it can tell you about other things like iron and melanin. So it's actually quite informative, but it involves using, I would say, multiple modalities. And that's a big take-home message, I think, is that people often ask, well, which is the best approach? And I would say all of them. You can't, it's not worth fighting over whether one type of scan is better than the other. They're all informative in different ways. And so you really want to try and combine the type of information.
So from a practical standpoint, oh, are you there, Jon? I think you froze for a second.
I've lost you, Indu.
Okay, are you here? Are we together now, or? Uh-oh. Are you frozen? Jon?
I
You're back.
thought you were, but maybe it's me. Yeah.
I think it was you because I saw them moving. So I think people are just asking from a practical standpoint. Let's say you're a patient with Parkinson's type symptoms. You go to see a doctor and you haven't quite confirmed your diagnosis, but you're, let's say, you're in Canada right now and you come into your clinic, let's say, and you are evaluating that patient and you see some symptoms and you see some signs and things on the exam, you hear about the symptoms. What are you using, from a clinical application perspective? Because I know a lot of this is research and really, really cool and interesting and stuff. But look, from a patient's perspective, if they just go in, do you recommend, ordering this type of scan for confirmation of the diagnosis or at any point in the clinical things? And if so, what would lead you to order a test like this?
So I'm really glad you asked that because I have made myself intensely unpopular for many reasons, but one in particular is based on the answer I'm about to give you. I'm actually a pretty old-fashioned clinical neurologist, and I trained in the era when CT was relatively new and MRI just came out when I was a resident. So I think the best diagnostic test is a history and physical. And I still lean very heavily, most heavily on that. And for most people who I see who I think have typical Parkinson's, I don't get any lab tests. Now, if I think there's an atypical form of Parkinson's, then I think it's quite reasonable to get an MRI to look for the patterns that are typical of PSP or MSA. It's probably not absolutely necessary to do that. And as you said, most of the things I'm talking about are predominantly helpful for research. Now, there's always examples where it's going to be helpful. So a DAT scan, if you're really having trouble, if, for instance, you've seen somebody who's being treated with dopamine blocking drugs like antipsychotics, well, a DAT scan can be quite helpful to tell you whether or not there's loss of dopamine cells. Or if you're really having trouble between essential tremor and Parkinson's in the diagnosis. But actually, in that situation, my diagnostic test of choice is to bring the person back for a second clinical evaluation several months down the road. Because most of the time, it's not that critical to be right. Where it is critical, I think, or more important, is if you're doing clinical trials of disease-modifying therapies, because then if you're including people who don't have the diagnosis of interest, you're basically going to dilute out the signal.
Yeah, I agree. And I think, yeah, good old history and physical. I went to school in the University of Toronto, and I think they really emphasized that is, and I still think that, in the hands of somebody who does this a lot, that will help you sort of with your clinical acumen, because I think some of these tests, especially as the DAT scans that are ordered here, are not quantitative. They're very sort of subjectively read. And so there's definitely been some times when I'm like, people are just disagreeing on even what they're seeing. And I think a lot of it has to do with the hands or the eyes of the person reading it. If they haven't read it enough, this is something, because it's so subjective, that can be misread. So I personally say that we should just, rely on history physical and then try some medication sometimes and see the patient back. But I think we came up with some guidelines at the VA, and one of them was if somebody's on a dopamine blocking drug, and they have confusing, things, and you're not able to take them off the drug, maybe the scan would be reasonable then. Also, these mixed tremors, especially if you're considering a surgery and you have a very confusing tremor, sometimes it's helpful. And then, otherwise, I don't think there's a lot of reasons why we order these just in the clinical practice. So I think, that hopefully will help a number of the folks in the questions here is asking, when they should get it. And even with the Parkinson's plus disorders, I think, follow up and close sort of exams and histories is probably pretty helpful for kind of sorting those out as well, right? So one of the questions is about sort of the sense of the placebo response and sort of what you think about that. Since you did that, you were involved in that study in the first place. Have you sort of been I think one could say, and I think we spend a lot of time on this, program talking about exercise, talking about, these sort of different effects of a more holistic kind of approach, possibly, meditation, yoga, different sorts of things. And some of these things are very hard to study with controls and stuff like that. So what is your sense of using, imaging to help sort that out? Or do you think it matters? I mean, some people would say, I have colleagues that say, well, let's just use a placebo. If it causes dopamine release and you feel better, and you're doing it, then just keep doing it. So what's your take on that?
Well, that raises several issues of both scientific and ethical. So from the ethical perspective, I don't think it is acceptable to lie to people. So even if you get a positive response that is beneficial, I think that falls outside acceptable behavior. What you could do is enter into a discussion with the person and say, I don't know how you respond to this medication. I would like to, with your permission, I would like to compare active drug to placebo. And I'm not going to tell you when I'm giving which one. But I don't think the old-fashioned approach of just blindly handing somebody a placebo and telling them that it's a new drug, to me, that really violates the principle of autonomy.
Yeah.
Now, from a scientific perspective, I think the interesting aspect is not whether or not you can detect it. I think, well, I mean, that was interesting for sure, but I think basically that we should not regard this in a pejorative fashion, that it's a very physiological thing. So we shouldn't separate. It's kind of like a mind-brain dichotomy. It's the same thing. So placebo has an effect that is mediated by defined or incompletely defined physiological mechanisms. And the placebo effect in Parkinson's is not going to be the same as the placebo effect in other conditions. And I could have shown you evidence for that, but there are different mechanisms contributing to placebo effects in, say, pain and depression.
Yeah. Such a fascinating area for sure.
Oh, and I would just say on exercise, one of the controls that we put in, I didn't talk about that, but an important thing for us was to control for social interaction. When you look at the early studies that were done on exercise, they had a bunch of people who were brought together where they would exercise in a group and they'd go out for a latte afterwards. And they compared that against people staying at home doing nothing, or maybe, watching Oprah. And it's not only the physical exercise then that makes the difference, because you're getting people together in groups. So it's really critical that you control for that.
Wow. So it sounds like you're a fan of socially connecting then. Is that what you just said, Jon?
For other people, don't do as I say, not as I do.
Well, I think you and I have had a happy hour, a virtual happy hour or two with our colleague who actually is moving chunks of brain and looking at them under a microscope. So I'll have to send him your video of this recording to show him that you don't actually think that that's terribly helpful. It would be better to do imaging. I'm joking, but if anyone wants to watch an amazing talk, look at Harry Venters. We had him on last year, an amazing fellow Canadian and friend of both Jon and I. Anyway, this has been such a lovely discussion. I really appreciate your taking the time. Maybe we could have you just give us one last, maybe inspirational thought or message of hope to our viewers out there. And again, thank you so much.
Well, I'll try. I think the exciting thing is that there's a huge amount of stuff changing in the Parkinson's field, and that really the more we understand about the brain, first of all, it's worth understanding for its own right, just like looking at beautiful art. But also the closer we get to being able to do something about it. And that sometimes the things that we need to do are not necessarily high tech. The high tech stuff is great for understanding brain function, but really what we've learned over the last few years is that things like exercise, diet, adequate sleep may have as big, if not a bigger impact on the course of Parkinson's. And you can actually demonstrate that using imaging. So basically you can use a very expensive tool to tell you that your mother was right all along.
Yeah, I feel like that's what I'm doing. I'm learning that every day. It's kind of crazy, but my mom is a gifted family doc in Hamilton, Ontario, Canada. So she's been right many times over. So anyway, thank you so much, Jon, for sharing your brilliance with us and joining us for this hour. And I will pass it back to Sarah for our goodbye wave and socialization. We do this wave.
Yes, for socialization. And I also can't thank you enough. This was so interesting. By the way, everyone who's on, I'm putting in the chat, I would love to ask each of you, and if you're a care partner, you take it as well, and the person with Parkinson's takes it as well. Quick survey, it's going to take you like 7 minutes, but it's a quick kind of quality of life survey that we're just doing a little touch base checkpoint. If you have a minute, please do that. Thank you so much, Indu, for this. Jon, that was fantastic. Let's give him our friendly wave, our big thank you.
Thank you,
this
everyone.
This is how we send hugs across.
You can open up all the
world.
screens and just scroll through. There's like 100 and something people like waving at you right now, Jon. So.
It's so much fun.
You're kidding.
No, seriously, it's like they're all on there. It's pretty cool. Yeah.
Well,
anyway.
thank you very much, everybody, for having me.
All right.
Thank you so much. Okay, take care.
Thanks.
Bye-bye.
Bye-bye.